The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Thanks for joining us today for our webinar. I'm Carmen Boone, Education Coordinator from Oregon Pacific Area Health Education Center. And today I will be your host and moderator. Let's go over some housekeeping items. On your GoToWebinar control panel, you will notice that all microphones are muted. They will remain muted during this session. If you are experiencing audio difficulties, make sure your computer speaker volume is turned up or use the phone option to listen in. Slides can be downloaded from the handouts option. And also, we will email them to you within 1 week. Please use the questions option for typing questions or comments at any time, and questions will be answered at the end. If we run out of time, we will still answer your question via email, and we will email you in that case the Q&A within a week. This webinar is being recorded and will be available on our website at the address that you see on your screen, also within a week. And if you have any questions, please email me at carmenb@somehealth.org. Now, to obtain CME or CE credit for this activity, you must log into www.eeds.com. Once more, www.eeds.com. And enter this activity code. We will email you the instructions tomorrow, but please write down this activity code for your records. This webinar is produced by the Oregon Pacific Area Health Education Center, a hosted agency of Samaritan Lebanon Community Hospital, and is presented by Dr. Amy Weiser. She is a family physician. She loves promoting health and wellness, and from these, the positive effects she sees in her patients. Her clinical interests include gynecological health, maternity care, and gender-affirming healthcare. Dr. Weiser and the planners of this activity report that we have no conflict of interest or relevant financial relationship with any commercial entities that might affect the contents of this presentation. We will show you the code, the activity code, at the end of this presentation. Now, without further ado, let's start with the webinar. Here is Dr. Amy Weiser. You're muted.
I just got that. Hi, Carmen, and hi, everyone. You would think after months of doing this, it would be I would be a lot smoother with this, but of course, every day is a new adventure. I hope everybody's doing well and taking care of themselves. And thank you for spending the time joining me today. So I'm going to go ahead and share my screen. Let's see here. Okay. Alrighty, and I'm going to turn my own camera off. So you should be able to see me or hear me, but not see me. So we're going to be talking about using quality improvement practices to increase the HPV vaccination rate in your health system. So as Carmen had said, I am a family doctor. I work at OHSU in Portland. And I am a huge HPV champion and advocate within our own system, but also in the systems that I've worked with before I've gotten to OHSU, which is rural family medicine. So moving on. Okay. All right. So I have no financial relationships or conflicts of interest. I do want to share that content of this presentation is from the CDC You Are the Key to Cervical Cancer Prevention slide deck a deck that you may have tuned in and seen me talk about in the past. Thank you for doing so if you have. If not, it is great content, and I would definitely direct you to go to the CDC and review it. And then another portion of this presentation is from the American Cancer Society, including their toolkit for steps for increasing HPV vaccination in practice. So we'll be reviewing both. In this hour, our objectives are to review evidence-based interventions and action strategies for HPV vaccination rate improvement. So we'll be reviewing the toolkits. We'll also develop some self-efficacy and delivering effective HPV vaccination recommendations. And then we want to model some resources which could be applicable to your own practice. And each practice is a little bit different, so it's not a one-size-fits-all, but we want to go through it and see what you could pull out of this talk and apply in real time. I thought it appropriate to start with an overview of HPV epidemiology. And some key points are that most females and males will be infected with at least one type of mucosal HPV at some point in their lives. So this includes basically everyone. It's estimated that 79 million Americans currently are infected with HPV, and that there's approximately 14 million new infections per year just here in the United States. We worry about the high-risk types, those mucosal high-risk types, because these are the ones that cause the majority of cervical cancers, vaginal, vulvar, anal, penile, and oropharyngeal cancers. And we want to just note that most infections, they're most common in people in their teens and in their early 20s, and this is associated with sexual debut timing. Also important to note is that most people are never going to know that they've been infected. This is something that unless it becomes problematic or unless it's picked up on a cervical cancer screen, most people don't realize that they have. So before they become infected with HPV, we want to focus on a preventative strategy, and that's the HPV vaccine. And this chart demonstrates the HPV types that are targeted by each HPV vaccine. All 3 vaccines are still licensed in the US. However, since 2016, only the 9-valent HPV vaccine is marketed in the United States. So this is the one that you'll have in your office that you'll be giving to your patients. And this particular vaccine includes 5 other types of high risk, so 31, 33, 45, 52, and 58. So other high-risk HPV types that actually weren't included in the quadrivalent. And so we've had some expansion of the HPV types that are included in this vaccine. And these also count for a higher proportion of HPV-associated cancers in women when compared with men, and also cause cervical precancers. So expansion for these is a worthwhile inclusion. And then when to give the HPV vaccine. So recommendation is around age 11 or 12, and both girls and boys, so again, everyone can start HPV vaccine series as early as age 9. But we tend to go ahead and bundle the HPV vaccine at the time of a tetanus booster or a menactor vaccine. And so that's why we typically will say around age 11 or 12 to receive the vaccine. Ideally, teens should finish the series by their 13th birthday, because prior to age 15, they only need 2 doses. Starting the HPV vaccine at ages early or later than 15 will require a 3-dose series. So for everyone ages 13 to 26 who hasn't started or finished HPV vaccine, you should be vaccinating and targeting these people as well. So again, we want to have HPV given on time, which is around the ages 11 or 12, but we don't want to forget about those who may be a bit later in their adolescence or in early adulthood who are still eligible for these vaccinations. So originally the age range was between 9 and 26 years of age. And in 2018, the FDA actually expanded the approved age through 45 years in both women and men. In 2019, the ACIP, which is the Advisory Committee on Immunization Practices, they expanded this and they said that for adults aged 27 through 45, the public health benefit of HPV vaccination in this age range is probably fairly minimal, and that a shared clinical decision-making conversation is recommended because some people who are not adequately vaccinated at this age may actually benefit from this vaccine. But what does this mean? Because this is sort of vague. There's no fall-in or fallout criteria. And in 2020, just this year, the ASCCP announced a call to members recommending HPV vaccination for clinicians routinely exposed to the virus. So we have a little bit of clarity there. Later on, just over the summer, the American Cancer Society said that they don't support the ACIP, that recommendation in 2019, saying that adults aged 27 through 45 should be given the vaccine just because of low effectiveness and low cancer prevention potential of vaccination in this age group. There's burden of decision-making on patients and clinicians, and there's just lack of sufficient guidance on the selection of individuals who might benefit. So for this, the take-home message is that yes, this HPV vaccine is recommended from anywhere between age 9 to age 45, after the age of 26, so 27 and on, to really use your clinical judgment. And my guess is that there's probably going to be more to come on this specifically as to who should or should not receive this vaccination in their late 20s, 30s, and early 40s. But for now, use clinical judgment. And know that insurance companies are indeed covering this vaccine for patients of that age range. So your patients may come to you wanting to discuss this as well. And I would just recommend having a shared decision conversation with them. Okay, so what do we know about the HPV vaccine? Well, we know that it's safe. We know that the benefits of this vaccine far outweigh any potential risks. Studies are similar to Menactra and Tdap vaccine safety reviews. We know that the vaccine works. We have great population impact studies letting us know that there are early and mid outcomes after release of this vaccination. The studies are from multiple countries, and in fact, there was a review of 65 studies focused in 14 high-income countries that showed after 5 to 8 years of vaccination practices that the HPV 16 and 18 prevalence rate decreased by at least 66%, that anogenital warts, that incidence decreased by at least 54%, and cervical precancers decreased by 31% in ages 25 to 29. And this kind of moves us then to the mid outcomes, what we're seeing a little bit later on after this vaccine has been given for a significant period of time. We also know that there's evidence of herd effects, and this was an outcome from some early vaccination programs in multiple countries where anogenital warts decreased among boys and men in countries where males weren't actually part of the vaccination program. So there's some great studies out of Australia where they first focused on females, gave them the HPV vaccination, and then found some herd immunity was also transpiring in the rates of warts in men and boys. And then the last thing on this slide is that we know that the HPV vaccine lasts. Studies suggest that the vaccine protection is long lasting, so at least 10 years up to date. There's no evidence of waning protection, and multiple studies are in progress to continue monitoring of this as well. Right. So despite our understanding of HPV, and this was kind of a quick, but hopefully touched on a couple of key points here to get us all on the same page. Despite our understanding and all the data that we have, our HPV vaccination rates in this country remain low. And interesting is that globally, both low and middle income countries have achieved higher rates of vaccination. So if you look at the graph on the left-hand side, this conveys missed opportunities that we have. So for this study, which is a NIS teen study from the CDC from the years 2015 to 2018, kind of tells us about our percent of vaccination specifically for HPV in boys, girls, and then in all adolescents. And what we realized is that if we vaccinate HPV at all those touches, at all those opportunities or office visits where we give the flu shot or tetanus or Menactra, that we could achieve close to 95% of having the first dose of HPV given for our population. That's what is achievable based on the studies and some similar algorithms from other vaccinations. But what we're seeing in real time is that our actual vaccination rates are fairly low. They're only in the 60s. So we're not doing as good as we can. We can definitely do better. And the other thing that's important to reflect upon is that this isn't about actual resources. This is about the delivery of our resources. Globally, if other countries who are much poorer in gross national product than we are achieving higher rates of vaccination, it's all about the delivery. So what can we do to get better? And that's what we're going to talk about for the latter half of this talk. So effective strategies for improvement. We're going to take a look at this study, and this chart is from a publication from 2016 in the journal Pediatrics. The publication was called Interventions to Improve HPV Vaccine Uptake, a Systematic Review. And the authors noted that other countries have considerably more success achieving high rates of HPV vaccination. So they wanted to gain insight from these global efforts, and they conducted a systematic review of the literature for national and international initiatives to increase HPV vaccinations. They ended up looking at 51 articles that were published between 2006 and 2015. They took a look in 3 databases, so PubMed, Scopus, and Embase. They really did a fairly robust literature search. And what they found is presented here. So they used a framework from the Community Preventative Service Task Force to guide data extraction and synthesis. And this task force, the purpose of it is to identify successful health interventions. They conduct systematic reviews and provide frameworks to assess an intervention's design and execution. So the effective strategies to improve HPV vaccination rates really fell into 3 general categories. So informational, behavioral, and environmental. And what this shows is that there's no one best way to improve HPV vaccination. So multi-pronged approaches are invoked, and each practice really needs to find out what works for them. So let's dive into some of this, because I want to take a broader category and see how we can either apply it in our practices or how we noted this before. So effective strategies, of course, first of all, include informational, and this widely focuses on educational campaigns. So they could be individualized, they could be community-wide too. And the studies found that during these campaigns, improved vaccination uptake occurred. But after these campaigns ended, there was no evidence to suggest that the effect was sustained. So one example that comes to my mind is the One Last campaign that Merck launched in 2006 when they released Gardasil. And they used commercials, they had ads in magazines, there was this lovely jingle, I used to sing it. For whatever reason, my office put up with me singing it. But that was something that, you know, it was widely advertised, it got a lot of attention, and then the campaign ended. It was an expensive campaign. It was launched by a big pharma company. So it's not something that we can really, you know, do in our office or communities. We don't have any budget for it. But you can emulate some education in your community. You could use posters or handouts in your office. So anything that makes education or information present is an effective strategy. The next thing that the next category that I wanted to touch upon was environmental. So this can include things like school-based vaccine programs where there's absolutely an increase in access to vaccination. These can reach very large populations within a community of a school, or a school district might be quite diverse as well. And then another environmental strategy would be some international government initiative programs. So some NGO, WHO, UN family planning. So these are huge, more government focused initiation programs for vaccinations. And they're very common in low and middle income countries, not so much here. And this just goes to say, again, that high vaccination rates are not limited to high income populations. So taking this, what could be feasible in your community? Is there a school-based clinic that you could staff? Is this something that your community needs? Could you partner with a community organization? Maybe for some of us, maybe not for some of our communities. But something to think about as far as school-based may go is that for now, HPV isn't a required vaccination for school entry versus some other countries that do have it as a mandatory immunization. But it's getting there. It's not mandatory in Oregon yet, but in 21 states within our own country, as well as the District of Columbia, it is required for 6th or 7th grade students. So this could eventually become something that is required or a mandatory vaccination for school. Another category of effective strategies focuses on behavior. So there are different ranges of effectiveness depending on what behavioral activity is engaged in. This requires significant effort. And from the studies, there's been some inconsistent outcomes. But the bottom line is that the concerted effort required to optimize uptake of the HPV vaccine is actually ours. We need to make those behavioral changes. So what studies in general are showing is that multi-pronged interventions targeting both the patient and the provider are going to be the most successful. Now, if you're like, oh my goodness, how am I going to do this? I don't have enough time in my day. Guess what? The ACS really took care of this for us already. So they have some lovely toolkits available that we can use to model how we change our behaviors. And this toolkit was developed from the work of experts in the field, several of whom I've actually had the opportunity to work with through ACS and the NCI. It's very comprehensive, this toolkit. It's easy to follow and it's free on their website. So we're going to take a look at it for the remainder of the talk. Okay, so looking at this, first of all, small, nobody can read this damn thing. We're going to go through it step by step and not to be overwhelmed because it does make a lot of sense as you go through it. So the first step is assembling a team. Okay, we work with teams all the time, teams of dyads, of a provider and an MA, office teams. Team is a really broadly applicable word. So let's start with what we got. So we really need to have someone who is this very enthusiastic HPV champion at your clinic. This person needs to be able to possess authority to implement practice changes. So not in title only, but actually given some room to enact some of these strategies. And foreseeably having a little bit of time that's dedicated or carved out to work on this is ideal. This could be your vaccination for children champion, which a lot of offices usually have. It could be a general vaccination champion. It could be an administrator within your office. There could be a champion in each office if you're in a large system, or foreseeably, I practiced rurally at one point and we had 9 people in our office, both front and back office combined. And sometimes smaller teams are easier to get things done. So you can start at a very grassroots level, not super high in your institution to get things going. You want to form a QI team. You can meet regularly. You want to think about and enact the Plan, Do, Study Act, the PDSA process. And this QI team, one of their charges should be to review rates of vaccinations and set benchmarks. Okay, this is where we are. This is where we want to get to. And then create and update office policies reflecting those benchmark goals and the process of how you're going to get there. You can also identify some external organizations or resources in your community that could be supportive. So obviously, the American Cancer Society, the American Academy of Pediatrics, any local AHEC, shout out to Oregon Pacific. Thank you very much, guys. CDC has some great programs. There are clinic or county health officials, city health officials, and school clinics too. So your team can be as wide-reaching as you feel is going to be appropriate for your community. And now you're going to make a plan. So what are we going to do? Well, we need to identify opportunities to increase HPV vaccination. So what are we doing already? What's already there in our office, in our community? What strategies are we invoking? And are they working, right? So how do people come in and get vaccines already in our office environment? And then, how do we know when vaccines are given? And to talk about what we're doing already, sharing the results with your staff, transparency and full disclosure makes these plans and systemic changes for QI work so much better. You also need to determine what your baseline vaccine rates are, and you can calculate these, a little bit of math, but you can calculate these for patients who have received vaccination for each HPV dose, tetanus, meningococcal by the 13th birthday. And then you want to work to improve the accuracy of these baseline rates. So you want to identify your sources, and this can be looking at your EMR, it can be looking at paper charts and doing audits, EMR charts and doing audits, in your immunization registry through VFC. You want to determine a 12-month period of time for your baseline. COVID has screwed everything up. I fully acknowledge this. And so you can include COVID, you can do pre-COVID, it's all up to you. Identify patients who have turned 13 during this 12-month period of time, and identify patients who have received vaccines for each HPV dose, Tdap, and meningococcal by age 13, and then calculate your rates. The thing that I want to point out here is, where is your documentation and is anything missing? This is a good time to say, well, what is our protocol for data entry and verification to make sure that our records are accurate? We don't have a national registry for vaccinations. So it really does result in a potential barrier for clinics to figure out what their rates are because of this documentation that may be haphazard. Maybe this isn't the smoothest process. Maybe that should be looked at as part of your plan. So the next step is then, once you get your team together and kind of where we are already, is we want to design our vaccination strategy. So have you done any QI in the past? If yes, great. What has worked? Let's use that, right? So choose multiple strategies that build on past successes, and then create an HPV vaccination policy. What schedule do you use in your office? Do you start at age 11 or 12 or 9? And then when do you give that second dose? That second dose can be given 6 months to 12 months after that first one, if we're talking about a child less than age 15. So come up with a schedule that everybody will use and stick with as a policy for your office. And as you're doing this, who gives the shots at your office? Having administrators make these plans on paper might seem great, but in actuality may not come even close to the daily flow. We all realize that. And to ask providers who aren't giving the shots, I think that I'm probably missing some of the nuances of what goes on too. So incorporate staff feedback into your strategy design and implementation. One of the best resources are your medical assistants. They do it all. They know what's in the fridge. They know what families come in for vaccinations, which ones may not in the community. So definitely use their input. And then you want to assess and recommend HPV vaccination at every opportunity. So we want to really focus on HPV vaccine. It's a cancer vaccine, and we want to minimize missed opportunities of these immunizations. So step 3, engaging all staff and preparing them. You want to train all your staff to ensure a consistent positive message delivery to the parents and your patients. You can use human interest stories to increase staff investment, but suffice it to say is that even non-clinical staff can impact vaccination rates. So if misinformation is provided to patients, in particularly understanding the schedule of dosing, how many doses are in the series, and any insurance issues could definitely, making sure that that misinformation is not being propagated could decrease any vaccination barriers that may be present that you don't even realize. And then preparing the clinic system. So modify your EMR to accommodate the needs of your plan. So EMRs can track each dose administered, and you can train your staff on how exactly to enter and extract data from the EMR. And then the last thing is to ensure that vaccine supply and storage needs are not met. You want to make sure that you have the vaccine, but not too much so that it expires. Keeping all staff on the same page, that can also seem a little bit daunting, but you know, there are great handouts from the CDC for this. You want to make sure that your communication aligns with your mission of increasing your rates of HPV vaccination because this is a cancer vaccine. You want to reinforce HPV vaccination as the norm, just like parents choose to vaccinate their child as infants. This is not an extra. You don't want to accidentally undermine yourself from thinking that this is an outlier or an add-on. Everyone should be using clear, consistent messages, sharing key points, using the Talking to Parents handout, and just educating and making sure that you allow opportunity for any questions, any concerns, any feedback that may come up, because this will help to keep everybody on the same page. And then again, engaging and preparing all staff. You want to prepare the parent and the patient. So providing targeted educational materials can be great. So the next question is, well, what would be those educational materials, and where are we going to display or distribute them? Do you have any papers in your waiting room? Any handouts there? Any material in the exam room? You know, where and what do you want to display? And then preparing clinicians, so training clinicians on how to effectively communicate with parents and patients, and providing targeted provider education materials. So doing things like this talk, going to the CDC, making sure that you're paying attention to CMEs, looking at the You Are the Key to HPV cancer prevention, are all great avenues that are already prepared that no one has to come up with per se. Okay. And then get your patients vaccinated by their 13th birthday. We want to make this an effective recommendation, and to do so, you want to be gender neutral. This is not a girl vaccine or a boy vaccine. This is an everybody vaccine. Ages 9 through 12 is what your target audience is, and you want to talk about the vaccine in the same way as other vaccines and give it on the same day as other vaccines. And then you want to think about, you know, educating the healthcare providers. So ensuring clinicians know that a patient is due or overdue for HPV vaccine. And so doing a team huddle in the morning, scrubbing charts in the morning can be part of the routine, saying, okay, what kind of health maintenance is due, and making sure that HPV is on your list of health maintenance. So a little bit about framing the conversation, how to talk to patients and parents. CDC supports the following: to bundle recommendations, consistent messaging, using every opportunity to vaccinate, effectively answering questions, and then also providing personal examples. So some of you may have seen these slides before in the You Are the Key, but I thought that they were important enough to bring into this talk as well. So top reasons that parents aren't starting HPV vaccines, well, one of the top 5 is that the vaccine wasn't recommended. So remember that parents themselves may have been older than 26 when the vaccine was first released, and they may not know it even exists. I mean, really, if I wasn't in medicine, I don't know if I would have known that HPV vaccine exists. And if they never got it or learned of it, how can they anticipate that their child needs it? So making sure that we do our job in recommending this vaccine. Also noting that clinicians really underestimate the value that parents place on HPV vaccine. So a study was done and published in Vaccine in 2014. This was out of Texas. And parents were inquired as to how much value they put on the 6 vaccines or the 5 vaccines and then any adolescent vaccine. And the parents' responses are in the dark blue. And then the same question was asked of the clinicians, how much value do you think that parents place on these vaccines? And we realized from this is that there is a huge disconnect here. The clinician's estimate, which is shown in the light blue, really underestimates the value that parents place on HPV vaccine. And so, this large disconnect between parents and clinicians is notable. The perceived and the real concerns of parents influence how clinicians recommend HPV vaccine. So how to address vaccines? Well, we want to do a bundled recommendation. It bundles all the vaccines recommended for preteens into one effective statements. And so we're going to just move into some samples here. So talking about vaccines the same way on the same day. So we want to recommend HPV vaccine the same way you recommend Tdap and meningococcal. And you want to do it on the same day. So we're not going to wait. We can give this vaccine today. You also kind of want to sandwich. So saying your child is due for tetanus, HPV, and meningococcal vaccines. You're not saying, oh, Tdap and meningococcal and then putting on HPV at the end is kind of an afterthought. You're sandwiching it in the middle. And so you're giving it the same attention as importance as the other 2 vaccines. And, some patients and some parents are going to be interested in vaccinating, but they're still going to have lots of questions. So interpret a question as in need of additional reassurance from you, the clinician they trust with their health care. And make sure that you're asking parents about their real concern. So some common questions: why does my child need HPV vaccine? You can say, well, it's important because it prevents cancer, and that's why I'm recommending your child start the HPV vaccine series today. Another common question: what cancers are caused by HPV? Because remember, parents don't know. Patients don't know either. And you can share that, hey, persistent HPV infections can cause cancer of the cervix, the vagina, the vulva, cancer of the penis, and cancers of the anus and the throat. We can help prevent infection by starting the HPV vaccine series today. Next question: is my child really at risk for HPV? Well, you can share with them that HPV is super common and infects both females and males. Remember, 80 million people have been infected and 14 million new cases occur a year. How long can we wait and still just give 2 doses? Oh, this is a common question. And I really say, I kind of ask the patient, do you want 2 vaccines or 3? And they look at me quizzically and they say, well, 2, obviously. So let's start that 2-dose schedule as long as you're before your 15th birthday. And then waiting for kiddos when they get older, they get more busy in different activities. It's harder to get them into the office. So it's best to start the series today so that your child is protected as soon as possible. And we don't forget. We only want the vaccines needed for school. Okay. So school entry requirements don't always reflect the current recommendations to keep your child healthy. And we saw this because HPV is not mandatory, although in 21 states and in TC, it now is. So this may eventually phase out as public health and political recommendations align themselves moving forward. Would you give an HPV vaccine to your kids? Answer this as honestly as you want to. Some people have no problem sharing. I told, I think everyone knows that my child has been vaccinated against HPV. She was very excited. She knew that this would be a big thing because she knows what mom does for a living. But you can also say, hey, the American Academy of Pediatrics, the American Academy of Family Physicians, NIH, the CDC agree that HPV vaccine is really important for your child. And if your patient denies, well, that's okay. This isn't a final thing. That is not the final answer. The conversation can be revisited. And you can ask them, okay, if you don't want to pursue this today, do you want to read up about this? Do you have any specific questions that we can revisit during your next appointment? So, coming up with one action item that you can both agree on to continue that conversation. I have patients every year who decline the flu shot. Am I going to not ask them the next year? No, I'm going to ask them the next year. Do they know that it's coming? Yeah, they do. If I don't ask them, do they call me out on it? surprisingly, they do. And so, you know, this conversation is not final. It continues. We breeze through these pretty quickly. There is a lovely How I Recommend vaccination video series to the CDC that you can go to for further information. Back to the toolkit, the action plan step 4, get your patients vaccinated by their 13th birthday. So increasing access, so incorporating standing orders into clinic procedures, providing walk-in or immunization only appointments can be something that your office can think about formulating if it hasn't already. And then reminding parents when it's time for the next dose of vaccine or when the vaccine is overdue for their child. So tracking completion of the series as well as follow-up is really important. So when do you need to come back? Well, since your child is younger than 15, they need a second dose, a second shot in 6 months. Or if your kiddo is already 15, they need a second shot in 1 to 2 months. And then the third shot is in 6 months. When you check out, make sure to make an appointment for that second and even that third shot, and then put that appointment on your calendar before you leave today. So taking that to-do off their list, getting them an appointment and a time and a date, having it on the calendar definitely increases compliance for completion of the vaccination series. Improving your immunization rates and overall healthcare delivery, you want to be able to combat that immunization information gap. So displaying chart reminders, this can be on paper charts, it can be in an EMR for all healthcare members. If you use chart reminders, the drawback is that it only reaches those who are physically in the office, but it works to decrease any missed opportunities at an office visit. And it should be listed on any office visit type. Standing orders, again, these can apply to all visit types. Mail and phone reminders, this can be a strategy that, depending on resources you have, it could be automated or it could be very time intensive. And it also requires patients then needing to follow up and scheduling a time for an immunization or an appointment. And what works for one practice may not work for another. Our rural practice did a mailer reminder. We probably sent it out to maybe like 200 people, and I think we got 17 responses. So obviously that did not work for our practice. And so we needed to come up with other strategies, and we did. And then getting your patients vaccinated by their 13th birthday. So measuring and improving performance. So conduct those PDSA cycles. You know, okay, this is where we started. We made this intervention, and then these are our results. So looking back, did our efforts gain us growth in our vaccination rates? And if it didn't, you know, recycle the cycle, take a different approach to it. The first time you do this, you may not get the benchmark that you strive for. You want to measure the number of missed opportunities as well, and ensure that providers know their individual rates as well as the clinic rates. So knowing the clinic rates is one thing for immunization. Our office at OHSU, we are very transparent. And so we have kind of our overall office, our overall team, we have several teams, and then we have it based by provider. We have this dashboard where there's your vaccination rate, there's your A1C at goal rate, there's your blood pressure at goal rate, there's your mammogram, you know, completion rate, and it's posted. Everyone can read it, including our patients, and it is okay to be transparent. And for times when my rates are lower than one of my partner's rates, I'll be like, hey, what are you doing differently? What did I miss? And so this is a great way to motivate for change. No one wants to have the lowest rates. Those with the highest rates are eager to share their successes and what they did, so that overall the community can really benefit from it. So overall, we can all do better. You know, you don't know what you don't know, so you got to do the work. You got to make the changes, trend your rates. And from this, we want to improve vaccination rates in our communities. And that's really the bottom line. Staying up to date is also very important, as immunization recommendations do change sometimes. So there are multiple education products available free through the CDC website. There's immunization courses, there's net conferences, there's some different self-study, you call the SHOTS modules, and there's always some continuing education available. These are my references, and I just want to thank everyone for coming today and listening to me chat. And if you have any questions, we can certainly address them now.
Thanks, Dr. Weiser. Checking to see if we have any questions. Let's wait for a moment. All right. Please use that questions section there on your control panel from GoToWebinar to write any question. You could use the chat option too. Let's see. Let's rock our brains for a little bit. All right, well, it seems like we don't have questions, so everybody was well received and understood. Thank you so much, Dr. Weiser. To all of our attendees, I'm so sorry about that. If you have a question, please email it to me, and I'll make sure it gets to Dr. Weiser and we'll be able to answer it to you. Let's review some of our information. So thanks for participating today. To help us provide best future training events, please take a moment to complete the survey that will appear as soon as the webinar ends. We will email you the Q&A as soon as we get questions by the end of the week. And the webinar recording will be available as well within a week on our website. You can see there on the screen. We have a question. Fantastic. Let's see. Okie dokie. Let's open these. Second. Okay. We get compliments. Such good information, Dr. Weiser. Question here says, I'm not in a clinic setting, but love the presentation about evidence-based practices you promoted. We have another comment or question. Dr. Weiser, have you experienced that religion cultural barriers play a significant role in limiting vaccine participation?
So yes. Interestingly, my practice now, we have a lot of international patients who have, or people who have moved to Portland, where I practice, to study. So a lot of students at PSU end up coming to our clinic. And so I have a lot of people from the Middle East who have different thoughts about HPV and sexual activity. I've also worked in a rural area, and rural areas can be a little bit more conservative, thinking that HPV vaccination could be kind of that green light to start sexual activity. And so I think that through these interactions, have a conversation and get to the root of what is the real concern, kind of weed through what a family might be worried about, the implications or the inferences, making sure that you really convey the message that this is a cancer vaccine, that this is not a form of birth control in any way or anything like that, that this is a cancer vaccine, and that we want to immunize your child against HPV, just like we would want to immunize your child against polio or pertussis or any other disease that we are trying to make preventable. But really, not making any judgment, having a great conversation about where they come from, what their narrative is, and then sharing information, making sure that you're dispelling any misconceptions or misinformation that they may have received already, and doing so in a very professional manner.
Thank you so much for the reply, Dr. Weiser. Now let's continue with our details for the end. Again, this webinar is being recorded and will be available within a week on our website. Feel free to reach out to me or to our office if you have any questions or concerns. We'll be happy to be of assistance. Now, finally, to obtain CME for this activity, you must log into www.eeds.com and enter the activity code that I shared with you on the chat and I mentioned earlier. You can see it again here. This is the activity code for today's webinar. Please write it down for your records. And please, at the end, complete your the survey that'll show up. And now you have completed the webinar and you may disconnect. Have a wonderful day. Thank you, Dr. Weiser. Goodbye.
Oh, you're so welcome. My pleasure. Thanks, everybody.
Bye-bye.